Hi, and welcome, Biksegn, and welcome everybody else. So Biksegn is currently a lecturer in psychiatry in the Department of Psychiatry at the University of Gondar in Ethiopia. And what was it, about 3.5, 4 years ago, 3.5 years, Biksegn joined CPMH and UCT as a PhD fellow on the Amari program. And I had the honor of supervising him. And Biksegn completed his PhD with a couple of months to spare of the 3 years of the fellowship. So Biksegn is going to present on his PhD work and his interest around testing the feasibility and acceptability of interventions for vulnerable populations. So thank you, Biksegn. And we'll listen to the recording of the presentation, which Biksegn prepared because we weren't sure of the stability of the network. So we're going to listen to that, and then at the end we'll have questions and Biksegn can respond. Thank you.
Psychological treatments could have a big role to address the treatment. Hello, everyone. It's nice to see you once again. And thank you so much for joining me today to attend this seminar. And I would like to extend my thanks to the organizers for giving me another chance to present my PhD work for a larger audience. My presentation will be about depression and HIV/AIDS, specifically on adapting.
Sorry, everyone, is it on notes view?
Yeah, Claire, I see is the notes view at the moment.
Okay. All right, sorry about that. Let me start this.
My presentation will begin with an introduction. Hello, everyone. It's nice to see you once again. And thank you so much for joining me today to attend this seminar. And I would like to extend my thanks to the organizers for giving me another chance to present my PhD work for a larger audience. My presentation will be about depression and HIV/AIDS, specifically on adapting piloting group interpersonal therapy
Let's give it
treatment of
10
depressive symptoms for people with HIV/AIDS. My presentation will begin with an introduction, followed by aims and objectives, methods, results, and finally with conclusions. As introduction, depression expected to affect over 300 million people according to the WHO report, which is equivalent with 4.4% of the global population. Depression contributes to 68% of all suicide deaths, and it remains one of the barriers to achieving the Sustainable Development Goals. People with comorbid HIV and depression have 2 to 3 times greater risk of mortality than those without depression. This could be due to socioeconomic and psychosocial adversities associated with depression. This diagram illustrates the relationship between HIV/AIDS and depressive disorders and their health-related outcomes. HIV/AIDS and depressive disorders are expected to have bidirectional relationship, and these conditions together could lead to poorer health-related outcomes. For example, these conditions could lead to poor adherence to treatment, poor immunological functioning, high viral load, and finally high risk for mortality. Of course, there are also other mediating and exacerbating factors, for example, psychosocial, socioeconomic, comorbid, and uncommunicable conditions, plus neurocognitive and substance use behavior could worsen these conditions. More than 80% of people with mental disorders, including depression, reside in low and middle income countries, but more than 90% of them remain untreated. And only 1 in 27 people with depression in low income and 1 in 5 in high income countries are receiving minimal care. Of course, there is a huge difference between low income and high income countries, but still the treatment gap is reflected in high income countries as well. In Ethiopia, there is no standard mental health policy or legislation, and the number of mental health professionals are 1,739, which is 1.74 per 100,000 population. And the WHO 2006 report, almost 15 years old report, indicated that the government of Ethiopia allocated 1.7% of the national health budget to mental health care when mental health conditions remain the most prevalent conditions in Ethiopia. The treatment gap could be bigger in the HIV population than the general population, as more emphasis is given to HIV treatment in HIV clinics. So what we need to address this huge gap in low-income countries, we need more interventional research, we need cost-efficient interventions that can be accessible for low-income communities. Psychological treatments could have a big role to address the treatment gap, and day counselors should be preferred delivering agents because they are expected to be cost effective, speak same language, and share same culture with clients. But psychological treatments are not universally effective due to their high cultural sensitivity nature. Therefore, cultural adaptations are needed to be implemented in low-income settings or in different settings or population. The aim of this research was to explore the problem areas of interpersonal therapy to enable us to know the intervention areas and to adapt and pilot the group-based interpersonal therapy for treatment of depressive symptoms among people with HIV/AIDS. The objectives of this research were to systematically review the existing evidence in low and middle-income countries on psychological therapies, particularly for people with HIV/AIDS, to assess major depressive disorder, adherence to ART, and quality of life, and to adapt the WHO group interpersonal therapy, and to pilot the adapted intervention to evaluate its acceptability and feasibility. Mixed study designs were used to address these objectives. We used systematic review and meta-analysis to summarize the evidence in low-income countries, and we used cross-sectional research to assess major depressive disorder, ART adherence, and quality of life. And a formative qualitative study design was used to adapt group interpersonal therapy. And for piloting, we implemented a single-arm interventional study. This research was conducted in Northwest Ethiopia, which is indicated by the red spot on the map, and the photograph indicates the waiting area of the ART setting where this research was conducted. Now let me move to the results section, and first let me go to the results of the systematic review and meta-analysis. 19 studies were included in the systematic review and meta-analysis, and 40 of them were included in the meta-analysis. 8 trials used cognitive behavioral therapy, and 12 studies used a group-based approach, and 7 studies used non-specialists as counselor. Number of sessions ranged from 4 to 16 sessions. The mean, median, and mode of number of sessions was 8. Meta-analysis results indicate that the effect size of trials ranged from none to large. Pooled effect size at post-intervention evaluation was negative 0.61, and the effect size increased to negative 1.49 at 6 months follow-up. Pooled effect size of group-based trials was negative 1.04, and similarly the pooled effect size of individual-based trials was negative 1.12, which is almost similar with group-based trials. And there was no difference in effect size between interventions delivered by lay counselors and psychologists. In overall, group support psychotherapy, interpersonal therapy, problem-solving therapy, peer counseling, or psychoeducation seem to be effective in reducing depressive symptoms. Psychological treatments delivered by lay counselors may be as effective as therapies delivered by specialists. Both group-based and individual-based psychological therapies showed similar effectiveness in our systematic review in meta-analysis study. The findings of this chapter is published in Journal of Affective Disorders, so that you can read the full text out there. The second section was the survey part, and in this section we used a cross-sectional study design to assess the magnitude of major depressive disorder, adherence to ART, and quality of life. With particular emphasis, we examined factors associated with a major depressive disorder so as to identify the intervention areas to address major depressive disorder. 391 participants were included in the study, and 2/3 of them were women. The mean age of participants was 38.7, that ranges from 18 to 78. 3/4 of them were on first ART treatment, and the prevalence of major depressive disorder was found to be 32.5. As indicated in this regression table, several factors were found to have association with major depressive disorder. For example, being divorced, being widowed, being illiterate and unemployed, and also having low perceived social support were associated with major depressive disorder. Adherence to ART was assessed using self-report questions. As indicated on this table, 81.9% of participants had reported high adherence to ART. That means they have taken all their medications in the past follow-up. Major depressive disorder was associated with reduced adherence to antiretroviral therapy. When we come to quality of life, have had significant relationships with several factors. For example, tertiary education, first-line ART treatment, longer use of ART medications, and high score of perceived social support were positively associated with overall quality of life. Functional disability and major depressive disorder were negatively associated with overall quality of life as well. The overall assessment indicates that psychosocial problems contribute for onset of depression, so that addressing psychosocial problems may help reduce depressive symptoms, and addressing major depressive disorder can help improve adherence to ART, and it can improve functioning, and this all could help improve overall quality of life. The results of this section as published in BMS Psychiatry. And the third objective was the formative qualitative study, which was the adaptation part. In this formative qualitative study, we conducted 3 separate focus group discussions with case managers, adherence supporters, and service users using a case vignette for discussion. The case vignette was presented as a major depressive disorder with suicidal thoughts. A total of 18 people participated in the focus group discussion, and all case managers and adherence supporters had secondary level of education. Several themes emerged from the analysis of the data. For example, name of the problem, perceived cause of the problem, and symptom severity and effect of the problem indicated in the case vignette, and treatment preference of delivering agents, and preferred delivering context or format of intervention, and perceived barriers were some of the main thematic areas appeared in our analysis. Participants listed different names for the given condition in the case vignette. For example, they name it Dibert in Amharic, Medabet, which are equivalent with depression, and some others said depressive problems, saying in Amharic, yeah, Dibert trigger. For example, one client said, I call it Dibert or depression, but there are other people who calls it Dibati, particularly mental health professionals call it Dibati. Participants reported that depression is caused by psychological, social, biological, and spiritual causes. As illustrated in the table, more of the causes listed by participants were within psychological and social element. And affective and behavioral symptoms were predominantly mentioned by participants. For example, one case manager reported that I was crying day and night, holding my baby on my arm. I was extremely sad, worried, no food and drink in my mouth. There were many people around me, such as my husband and family, but I was feeling hopeless and helpless at the time. This quote has several just manifestations like hopelessness and helplessness, which are affective symptoms. The presented case of a major depressive disorder in the case vignette was perceived as having severe and moderate problem. One adherence supporter said that I would say the presented case is a severe problem because she has a wish to die. She would die if she were in the right time and place. And depression perceived to have several effects on people with HIV/AIDS. One adherence supporter said that people with depression do not take their medications properly. At the time of that miserable time of depression and hopelessness, they would prefer to die rather than extending their life a bit longer with the support of medications. Therefore, it's quite obvious that people with depression discontinue their medications commonly. This quote typically indicates how depression correlated with non-adherence with antiretroviral therapy. Participants had basic understanding of psychological treatments, and they described psychological treatments in different ways, and they name it as counseling, psychological therapy, talk therapy, active listening, psychosocial support, etc. And they couldn't clearly explain differences between therapies as well. One adherent supporter said that active listening treats many people who are in travel and those suffering from excessive worry and sadness. This quote indicates how active listening can improve psychological suffering of people with mental conditions. Participants strongly proposed the use of trained peer counselors to facilitate psychological interventions and psychological treatments. One adherent supporter said that peer counselors can communicate with clients very easily, including with their gestures. And participants perceived that group-based interventions could be acceptable if provided in convenient and private places, that means inside rooms. And one service user supports this idea, and he said group sessions should be conducted in a place that should be convenient for us and should ensure privacy. This client looks like very much concerned about confidentiality. Participants listed potential barriers that can affect the implementation of group-based counseling. For example, lack of transportation, not accepting depression as illness, lack of trained counselors, stigma and inconvenience for participants could affect the overall implementation of group counseling. For example, one case manager said that we have clients who are coming from different rural areas far from here. I'm afraid that they can pay fees for their transportation, or they may not have easy access for transportation. And transportation issue has been a big barrier during the implementation phase as well. The findings such as local names of depression, problem areas, suggested counselors, and acceptable delivery contexts were included in the WHO Group IPT manual, plus selection of facilitators, meeting space, and group structures were clearly described in the adapted manual. And the findings of this section also published in the PLOS ONE journal. Finally, the results of the pilot. A single-arm, peer-administered group IPT intervention was conducted with 8 weekly sessions from 15 August to 15 December 2019. 36 eligible participants were approached within 1 month recruitment period. 31 of them were willing to continue the intervention, and they were assigned into 4 IPT groups. 29 of them completed the intervention. That gives 93.5% of retention rate. Quantitative analysis indicated that depression scores reduced significantly between baseline and post-intervention, and the effect size was 1.74. Similarly, perceived social support and quality of life scores improved. At the end of the intervention, qualitative evaluation of the intervention was conducted among selected intervention participants and counselors, and most of the participants were happy with the intervention, and they reported benefits, particularly in resolving conflicts, social support, in gaining social support, and helped them to disclose their HIV status to their close family members. One client said that I had long-lasting conflict with one of my neighbors. She was a pain for me for a long time, and last week I greeted her and she hugged me with a smile. I felt as if a big burden has removed from my shoulder. So her distress was just removed after she just started a smooth communication with her neighbor. The other finding was satisfaction with peer counselors, and everyone were happy with peer counselors. One participant said that they were very supportive, like a family, like a mother and a father. Their words are encouraging and gave us a lot of hope. One participant commented that she wasn't happy with the unprofessional behavior of one of the counselors because the counselor was braiding her hair during the group discussions. And the participants were also asked to give their views on the number and duration of sessions. The sessions were conducted every week. That was accepted by many of them. Counselors argue that 90-minute session duration is too short to address every issue. For example, counselors wanted to see every group participant treated from depression until everyone feels healthy, and they suggested inclusion of more sessions, maybe up to 10 or 12 sessions. And views and on the feasibility of the intervention. General views of participants on the feasibility of intervention was positive. Barriers to attending group sessions were access to transportation, as it has been anticipated in the previous study. Public employment, for example, public employment was mentioned as a barrier because the bosses are not okay to allow them to come to the session every week. And social responsibilities, for example, having children at home and they are unable to have a brief time to attend sessions, and sickness in between people get sick because of their HIV condition, and stigma was also another barrier. One participant said that my home was far from the town. Eventually, I found it a good opportunity to go out of home for a good reason. So she wasn't happy initially, but later she get just involved in the therapy. In overall, the WHO group interpersonal therapy intervention program was recommended for a larger HIV population, but participants highly emphasizing on the need to establish collaboration with other stakeholders, for example, with non-governmental organizations, so as to make this intervention accessible for many people. The results of this section is published in the Pilots and Feasibility Studies journal. Finally, conclusion of our research. The procedures and outcomes of group-based interpersonal therapy were perceived as acceptable. Participants reported benefits in resolving psychosocial problems and were satisfied with counselors as well. Despite barriers, group-based interpersonal therapy was acceptable and feasible with a high fidelity for people with HIV/AIDS in Ethiopia. The overall implication of this study are the findings of this study contribute to showing the process used in adapting and examining the acceptability and feasibility of psychological treatments for people with HIV/AIDS and can be used as a baseline for future trials. As these are some of the group photos taken during trainings and also during the intervention period. Finally, I would like to take the opportunity to thank my supervisors. I'm very grateful for their supportive supervision. I also want to thank just mentors as well, and you guys just helped me a lot during my stay at the center. And thank you to Amari Consortium and to the University of Cape Town. I'm just here to take questions. Thank you all for attending.
Hi, and yeah, great. Thank you. Thank you, Biksegn. Oh, you're still on the line. Good. Yes. So it was nice to hear a really detailed presentation of your PhD, because so often you have to present a 5 or 10 minute snapshot. So it was really good to see the detail of it. There are no questions in the chat at the moment. Is there anybody who would like to ask a question? Catherine.
Thanks so much, Biksegn. It was so nice to see the whole thing together. It's really impressive what you've done in such a short period of time. So congratulations again. I guess my question is about, what are your next steps? How are you going to take this forward? Do you have plans for taking this amazing work forward?
Okay. Yeah, it's interesting that the question comes from you, Catherine. Thank you so much. Yeah, the next step is just studying this intervention more for in larger population. But first, I need to get funding and support from others, I think, and finding funds, and also just developing my research skills needs to be the priority, because the next step should be RCT, and for this level of study, I need to be more competent. So that's why just I'm looking for postdoc programs at the moment. Yeah, definitely I will just work on it in my just future career.
Great.
Any other hands up? I've got a couple of questions, if there are no others as well. Biksegn, yeah, I mean, the next stage would be an RCT to really validate your findings so far and to compare them to a control group. But thinking a bit further than that, what sort of things would you take into account in trying to scale up such an intervention?
Yeah, just for scale up, I think we need more trained counselors, particularly just from the case managers and adherence supporters, and from the north part. I mean, from our region, in Amhara region, we have, I think, more than 300 case managers and adherence supporters. So just providing a group IPT training for these case managers would enable us to scale up the program into HIV clinics. And in addition, I think more assessment or validation on its cost benefit analysis need to be addressed, because we are not sure at this level whether the scale up can take a lot of money or not. So before moving to that level, I think we need to just investigate this intervention more using the RCT trainings.
What will you change in the RCT in terms of how delivered?
Yeah, just a very important question. I think this program has to be given in communities, I think, outside the clinic areas, because there were few participants were not just happy on the setting. One client said that, oh, I feel sick when just I come to this ART clinic because it reminds me my illness, he said to the interviewers. So just moving from healthcare institutions to the community could encourage participants to come more and more. So I would change the setting, the intervention setting. Plus, just I would add more counselors. Like for now, case managers are involved, but we need to just provide the training for community health workers as well, just in providing this program, because community health workers are just more engaged with the community and they have great access with the community, and I would include them in the group IP training. These are some of the points maybe considering to revise in the next.
It's a tricky one about where to provide the treatment. I mean, the sessions, because some people say, well, if you provide it in the community, it's too obvious to others. And I don't want to come because people are going to stigmatize me because of it. In the clinic, you have the transport and as the one participant said, it reminds me of my illness. So it's a tricky one, and finding some kind of happy balance between them is an interesting question to look at. Craig.
Thanks, Margie, and thanks so much, Biksegn. Really great to hear your presentation. And so before I get to my question, just wanted to commend you on all the work that you did for this PhD. You really went above and beyond. You know, initially we discussed doing a systematic review and you said, no, I don't want to do a systematic review. I want to also do a meta-analysis, and you taught yourself how to do a meta-analysis and you executed it to a high level. You know, so really huge congratulations for reaching this stage. I just wanted to follow up on Margie's question and really ask a little bit more about what do you think the uptake of this intervention might be by the Ministry of Health in Ethiopia? I mean, is there interest from them? If you were to be able to show the case convincingly through a randomized control trial, do you think it's likely that the Ministry of Health would invest and scale up this intervention?
Thanks so much, Craig, for your congratulations, and thank you. Thank you so much. Yeah, coming to the question, yes, there is a great interest from the Ministry of Health. I was actually just involved in training, in providing training for case managers before joining the PhD program, and just I was very much aware about the plans that the Ministry of Health had for integrating HIV care, for just providing holistic care for people with HIV/AIDS. And in the MH gap, they have been working highly just in integrating psychosocial support for HIV. And in addition, they are also highly working on a peer support program. They have their own HIV peer support program for adolescents. Just they are trying to meet once in 6 months, twice a year. These are children who just acquired HIV from their mother horizontally, and they have their own self-coaching and psychosocial support program. This program has been in practice where just I have just conducted this research. So there is a great motive and initiation from the Ministry of Health and from the local sources. Actually, the hospital leaders were happy on this program, but the case managers, the leader, there was a leader at the top for case managers, and he said to me that no, just case managers are trained to provide HIV education, specifically on adherence and HIV education only. Just we are paying them from our financial budget, and we are not happy just when you are just engaging them in this ART program in another service, because we have inadequate number of case managers and adherence supporters, he said. But this can be overcome if sufficient number of case managers and adherence supporters are coming through the program. So there is an interest from the top managers. Of course, scratching kind of relationship could be there at the middle level of stakeholders.
Great, thanks very much, Biksegn. Thank you.
Thank you so much.
Catherine asks if you have any recommendations on the support and supervision required for the counsellors. I know you had quite close contact with them and it was a very short period, but what recommendations would you have for what you would do in the RCT, for example?
Is it specific to the supervision program?
Yes, and support.
Okay. Yeah, supervision is the most important part. Just I wasn't this much aware about the supervision part. I was this much concerned. Just I thought it could be simple, but when it comes to the practical work, supervision could be challenging, and also in what interval supervision has to be conducted, and by whom, and what elements had to be just assessed during the supervision. These were most important things. And actually, this comes in just simpler with me after we had frequent review meetings every week. Every week, we just sat together with supervisors and we discussed their findings and their assessment based on the checklists. We just had checklists, and then we just communicate and just everyone had their own score. So the checklists helped us a lot in just bringing the ideas together and just to discuss the gaps as well and to address in the future session, in the next session.
Yeah.
So it looks tricky, but it's very helpful and important for the progress of the intervention.
And I mean, also thinking about the scale up of the intervention, how would you manage the supervision there? Because that almost always is where it tends to fall down, because you know, in a tight study, we build it into the whole design of the study, but in the scale up program, it becomes more complicated. Any ideas about how you would propose in a scale up of the intervention, how to do the supervision?
Thanks, Maggie. We just been recording all sessions, and then the supervisors listen to those audio recordings. Just they listen all the sessions, audio record sessions, and they give just a point on the checklist. It's very time consuming and tedious. I would make it like just taking randomly, maybe once a month or twice a month. Maybe it's something important that can minimize the time and the labor it needs. Otherwise, it takes much time of the supervisors when they are just listening. They need time to listen and just give points for each checklist. So I would just take random stations, and I would also just pay attention for the relationship between the counselors and the supervisors as well, because the intimacy and the good relationship of the counselors and the supervisors could affect the rating of their protocol, because if they have good relationship, they could give a good point for that specific counselor. So the supervisors need to be independent and they have to be out of other profession. I think just similar, maybe from public health. I would take from the public health. Of course, the supervisors of mine were public health and the nursing in profession, which were who had no previous relationship with counselors.
I mean, scaling up is also on a much more longitudinal time frame, and so in a way, it might not require the same intensity that you need in an RCT or something.
Yeah, to add one point here, I think for during scale up, we need to establish a formal reporting schema, because that needs to be reported to the regional health bureaus and other big, health offices as well. So the supervision should be supported by formal reporting from the counselors to the top managers.
Claire.
Thanks, Margie, and thanks, Biksegn. Again, I think everyone said it's a really great presentation and great work. And I was just wondering, I mean, if there was anything from the participants or the counselors that they changed anything in their daily lives based on the IPT. Did they say, did the counselors feel the benefit themselves? And for the participants, do you think they tried some of this at home, sort of get some friends together and support each other? Did you hear anything about that in the interviews?
Yeah, sure. At the end of each session, each client has to take homework, what he has to just practice at home. So with the help of the homework, they try to solve their interpersonal or social problems. Particularly, they try to establish a smooth relationship after the end of the session. They just used to tell us stories like they had good communication with their husband, with their children, with their neighbor, etc. And how they just managed to just overcome their loneliness. For example, they just went for coffee ceremonies and coffee programs not to feel alone at home. And also how they manage their grief and their life change as well. They just used to tell us based on their homework. When they arrive for the session, within the first 10, 15 minutes, we just review, the counselors review the homeworks given to each client. So yes, such stories were very common.
Okay, great. Thanks, Biksegn. I think, loneliness and attending coffee ceremonies, I think I'd like to do that as well. That sounds great. So it's wonderful. It sounds like they're probably taking the skills into their lives and maybe encouraging their friends to also reach out when they feel lonely or address their problems. So that's wonderful. Thanks, Biksegn.
Are there any other questions that anybody would like to ask? I've had a thought also. We talk a lot about cultural factors as important, but in a way, there's a certain basic universality about the human condition and about mental health issues as well. How easy, how relevant would your adaptations be for, say, neighboring countries or other parts of Ethiopia where there might be different cultures?
Initially, just we've been, some feedbacks during my protocol defense feedbacks were I received some feedbacks on, like, people might not happy to talk in front of group members, but this didn't happen. Just everyone were very happy to speak out, especially when they're together, because they feel as if they're together, and because the counselors, I think, being HIV positive itself, I think, helped in this context, I think. So they were very happy to disclose their problems, whatever. And this has been actually indicated in the previous studies. Yeah, people may not speak in front of people in Uganda and some other place because the providers were because other people like paramedics, like nurses or community health workers. So confidentiality issues were very sensitive in those studies, but in my case, it wasn't. And one very important adaptation was on the 4 intervention areas of interpersonal therapy. For example, in the Ugandan study, they just didn't find loneliness as a problem. So they were excluded that element from their intervention. But in our case, it was the most common problem. So all the 4 problem areas were fundamentally important in our context and this population. Primarily, life change, loneliness, and dispute were very commonly reported. So this is another finding. And one important also adaptation point was the dynamics of the group. In other parts, just people, counselors were just gathering only, preparing a separate group for men and women, for children and adults as well. In this case, counselors and clients were not happy to have a separate group. They need to have sit together, men and women. So they need to see the dynamics of men in terms of gender. So we used a mixed gender approach in this context. And another one, the WHO recommended, of course, to run this intervention for 8 sessions. But the counselors feel that it has to extend a bit more until everyone feels okay. For example, up to 12 sessions, which is a bit important point as well to be addressed in future. And other contexts, of course, like place, time, this also matters. For example, in other studies, weekend times were preferred, but the weekend time wasn't convenient for our clients here, because if they came for intervention during the weekend, so people at home may just pose a question, where are you going on this weekend? Because clinics are closed today. So a lot of points can be reconsidered in the next phase of adaptation.
Yeah, so I mean, a lot of context, the geographical context, the social context, some cultural factors, but also the fact that, you know, you're in a very particular healthcare context of the ARV clinic where people know each other, the users also know the center. So in a sense, it might create a dynamic that facilitated having say, a mixed gender group, and things like that, versus, you know, might have been different in Uganda, rather than, I suppose, in a way, highlighting only cultural factors, but that there's so many other factors that might be determining. Okay, I think there are no more questions in the chat. And anybody else, final comments? Can't see anything.
One very important point that I should mention, I think, before just ending up this session. I didn't actually pointed it out in my results section. Counselors or the people participated in the formative qualitative study were not happy to be seen by psychologists and specialists. They prefer case managers and adherence supporters or people with least educational background. They say that if you send me to a psychologist or mental health professional or psychiatrist, so I feel that my problem is bigger, that cannot be controlled with myself. That the professional or the specialist will tell me how much my problem is bigger than I expect. So that was a very interesting result that amazed me.
That is so interesting.
Yeah.
And, you know, I think, very interesting point to look into in more detail. Okay, we're coming to the end of the session. Thanks again, Biksegn, for putting the effort to record it as well before. And again, congratulations on graduating and producing this really big and important piece of work. So, I mean, this is not the end of our relationship at the Centre with you. This continues, and we look forward to that.
Yeah, I really missed the annex office.
All right, so there are just a few chats. Walter Magezi, thanking you for the chat, for the presentation. And interesting, raising the issue of whether you could transfer it to a developed country. And I think that's starting to be the time when we do need to ask those kind of questions. But lots of congratulatory comments in the chat as well. Thank you, Biksegn, and thank you everybody for attending. And we'll be letting you know about the next one.
Thank you so much, Margie, and all. It was a good time for me and to get some experience on seminars, because I'm not this much familiar what to present on seminars. It was a good experience. Thank you all.
Thank you.
Bye.
Bye-bye.